Dear students, I hope that you are all doing fine and are safe at home. My name is Dr. Ahmed Abdelaziz. Today we are going to talk about the articulators, which is a very important tool used in any prosthetic work, whether it's a complete denture or a single crown that is done indirectly in the laboratory. Articulators are considered to be a very important tool in prosthodontics, okay, and it is one of the most important armamentarium that is used to construct our prostheses. As I said before, whether it's a complete denture, full mouth rehabilitation, fixed or removable restoration, and it's as important as any other tool that you use, including your loops, your light, your mirror, etc., in the context of providing uh, a restoration that will function in harmony with the oral structures. I will start by the definition of the articulator. Articulator is a mechanical instrument that represents the temporomandibular joints and jaws to which the maxillary and mandibular casques may be attached according to a clinically recorded maxillomandibular relation, to have a permanent record of that relation, and to allow for opening and closing needed for tweed, sitting, or restorations construction in the laboratory, and also to simulate some or all mandibular movements so that the occlusal scheme can be verified in the lab before we move to the final step in which all restorations should be finally verified and corrected inside the patient's mouth. Now just to have a revision of our complete denture construction steps. We start with recording of the fitting surface using primary impression, after which we construct a special tray that will be used to make a final impression from which the master casts are going to be made, and which are the replicas of the fitting surface that will be considered the final record of that fitting surface, according to which further procedures are going to be conducted. Then on these master models, bite blocks are going to be constructed for both the upper and the lower arches. These bite blocks are going to be adjusted, of course, inside the patient's mouth to give the most ideal arch form that will follow the neutral resolve concept to locate the occlusal planes of the upper and the lower most appropriately, and to record the vertical dimension of occlusion according to which the teeth are going to be set and the dentures constructed, and also finally to have the maxillomandibular relation at that vertical dimension of occlusion recorded using these two bite blocks. As you can see here, the upper and the lower master casques were related to each other using these two bite blocks, okay, after being adjusted properly inside the patient's mouth and used to make the relation between the maxilla and the mandible. But before we proceed to the next step, okay, this relation should be kept and should be used to relate the two models to the articulator, which is the topic of today's lecture. Here, as you can see in the upper left segment, the maxilla, this is a case for real patient. The maxillomandibular relation was recorded using the upper and the lower bite blocks. Then, according to this relation, the upper and the lower models were mounted on the articulator, and after that, the bite blocks were replaced with artificial teeth. So we did teeth setting, and after trying inside the patient's mouth and verifying that the artificial teeth were set properly or adjusted and made properly accepted, after that the dentures were finalized and constructed, and of course all through these steps the articulators were used to adjust the teeth and set them according to the maxillomandibular relation that was recorded inside the patient's mouth. Here in this slide, we can see the two dentures related to each other, and they are also related to their respective casques. But also we can see the articulator on the right side. This articulator to which the upper and the lower models were fixed, and this fixation with plaster we call it mounting. Okay, The articulator has an anterior element, which is the incisal pin that is sitting on the incisal table, and two posterior condylar elements, in which the condyles attached to the lower member are related to the condylar housing of the upper member in the same way or in similar way to which the mandibular temporomandibular joint is related to the glenoid fossa, and we try as much as possible to make the movement in this articulator simulating the movement inside the patient's mouth so that this movement can be rehearsed and according to which the occlusion or the occlusal relationship between the upper and the lower models could be adjusted so that to have no interference inside the patient's mouth. As I told you before, this is a real case. It is not a conventional complete denture. Absolutely. It's an overdenture in which two remaining lower canines were retained and were used as overdenture uh, abutments that will fix the lower denture more securely when compared to a lower conventional complete denture. Now here we can see the upper and the lower dentures related to each other away from the articulator to have maximum intercuspation. Of course, this relation should also be exhibited inside the patient's mouth and before that on the articulator. Just to complete the picture of the overdenture abutments, here a bar is attached to the lower teeth that were root canal treated, the remaining roots, and on this bar the lower denture is going to click inside to have a more stable relationship. And here we can see the upper and the lower dentures inside the patient's mouth. What I want you to notice is that the occlusion here looks very similar to that which was on the articulator. And to be able to reach this result, we need to have a correct maxillomandibular relation and to have, according to that, correct mounting of the upper and the lower models on the articulator. And after that, to have the teeth sit accordingly and the occlusion adjustment done. Of course, none of the articulators or mountings is error-free, and that is why we need to complement all that with intraoral occlusal adjustment to end up with a correct occlusal relationship that is satisfactory to the patient and that will contribute to the health of the denture hearing tissues. Now we have a variety of articulators available for our use, and they differ according to their design and according to their adjustability. They can be classified into either non-adjustable articulators, average value articulators, semi-adjustable or fully adjustable articulators. And of course, the more complicated they are, the more precisely they can reproduce mandibular movements. But of course, more complication comes with more experience needed for their use and with extra cost and extra time needed for their programming. Here we can see the most simple, oldest version of articulator that was used maybe in the 18th century. Here, the upper and the lower models were related to each other using plaster of Paris that was then broken, so they could be assembled by hand, and by this the maxillomandibular relation was kept without the need of any sophisticated equipment. And here's also a very simple articulator, which is a barn door hinge articulator, in which we have a hinge and the upper and the lower member could open and close accordingly to keep the relation and to allow for opening and closing so that the upper and the lower models could be worked on to make the restorations. And here also an incisor pin was added that will be in contact with the lower member of the articulator to protect the upper and the lower models and to keep a vertical relation between them. A little bit more advanced type of the single articulators. Two joints were added here, and this could be attached to the upper and the lower models with super glue and then the joints fix with the super glue according to that relation, so that the mounting could be done really fast. Now here we have further development, okay, of the articulator in which two condylar elements are there. But of course, this is a simple articulator that is much smaller than our stomatognathic system, and it's made for economic reason that way and for convenience. Now here in this photo we can see more sophisticated articulators that are meant to resemble our stomatognathic system in a more in a closer way, and but they have different degrees of adjustability. So size-wise, they are close to our stomatognathic system size, okay? And from left, we have an average value articulator, or in this case, it is a mounting articulator that is not allowed to move to the right or the left, just open and close, but to have the same size or similar size to the average of human's stomatognathic system. In the middle, we have an adjustable articulator, which we call semi-adjustable articulator, and to the right side we have a more adjustable articulator. Even though it might be called a fully adjustable articulator, but there is no 100% fully adjustable articulator except for the patient's mouth himself. That is the most fully adjustable articulator that follows and resembles the mandibular movement to the highest degree of accuracy. Here we have a different view of the articulators just seen in the previous slide. Now we can say that the most left articulator is class 2 average value articulator. Average value articulators, they follow the Bonwell theory. Bonwell theory was based on measurements of mandibles of cadavers. Bonwell found that the distance between the two condyles and each condyle and the lower contact between the contact between the lower central incisors, they have equal value of about 4 inches. So that if you take two condyles and the contact point between the central incisors of the mandible, they should be part of an equilateral triangle with a side length of about 4 inches, and according to which the average value articulator was designed. In the middle, we have what we can describe as semi-adjustable articulator or class 3 articulator. Here the condylar element or condylar guidance angle can be changed in both vertical and horizontal directions. And on the right we have an articulator that can be further adjusted more to resemble more or less a fully adjustable articulator, even though, as described before, no articulator is 100% fully adjustable to the degree that it will represent the mandibular movement to the tiniest detail. However, it resembles it closer than the ones to the left. Okay. Now there is another classification of articulators according to where the condyle is located. In the most right one, the condyle is located in the lower, similar to what we see inside the patient's mouth. So it's more anatomical, and here we call it an archon type articulator. While the one in the middle, the condyle is located in the upper member and the condylar housing in the lower. This is called a non-archon articulator type. And here I think on the most right you have the BioArt articulator, which is similar to the articulators that you are going to use in the laboratory to do your practice, inshallah. Now here in this photo we can see a comparison between a simple hinge articulator, which is class 1 articulator, a non-adjustable one, and one of the more sophisticated, either average value or higher classification articulators. Now we can see that the simple hinge articulator is going to close according to the arc B. So it has a more vertical closing direction, simply because the occlusal plane is located higher and closer to the condylar element, which represents the center of rotation, closing and opening movement. Now, on the other articulator, which is more resembling the anatomical relation of our patient, okay, the arc of closure is going to be more forwards, okay, less vertical and a little bit having a horizontal component similar to arc A. So what we can say about this, if we set our teeth using the simple hinge articulator in which a more vertical closing path is going to be followed, some interferences that happen according to the A arc of closure are going to be avoided, and then we will set the teeth and they will open and close freely following the arc B, while when we place them inside the patient's mouth and when the articulator is going to close, or when the patient's mouth is going to close according to arc A, we'll end up, as we can see in the lower right segment, with an interference that will prevent smooth, proper closure, as could have been seen on the simple hinge articulator. And that is a representation of the error that can happen simply by not using an articulator that resembles the patient's movement to a high degree of accuracy. Well, in comparison to the previous slide in which we showed that the mandible can open and close according to an arc that is determined by the location of the occlusal plane in relation to the terminal hinge axis, which is an axis that passes through the two temporomandibular joints points of contact, okay, or stationary points during opening and closure. Also, the mandible can move in three-dimensional space. Okay? And now the condyles can be centers of rotation, or they can also rotate themselves or translate out of their most extruded position. And when they do so, the condyles are forced to move downwards or in another direction in relation to the maxilla, okay, because of the anatomy of the glenoid fossa. The downwards movement of the condyle is going to affect the teeth that are attached to the mandible and will cause some separation between the upper and the lower teeth closer to that downward moving joint. Now, to understand mandibular position, it's like any three-dimensional object. All we need to know is the location of 3 points attached to that rigid body. And it's convenient to think of these 3 points as the two condyles, the two posterior determinants of mandibular movement, and the teeth contact, which is the dominant contact anteriorly. When the mandible is moving out of its most extruded position, one or both joints are forced to translate. And with that translation, as I said before, that condyle is going to be forced to move in any direction other than the horizontal direction. And if it moves downwards, this will cause some separation closer to it. If both condyles move downwards, as happens when we do protrusion of the mandible, we'll end up with space between the posterior teeth, while the anterior teeth are still in contact in most of the cases. And that space phenomenon is called Christensen's phenomenon. If we can reproduce that space in the laboratory by changing the condylar guidance angle on the articulator, then that articulator can be programmed. Of course, that space can also happen when we move the mandible to the right or to the left, and is caused by translation of the non-working condyle. And again, when we try to reproduce that, we can also use it as a tool to reprogram or program the condylar element of the articulator in a way that will lead us to more accurate mandibular movement of the articulator in the laboratory. And as I said before, all that reproduction mandibular movement is needed to be able to create an occlusion that is in harmony with the opposing dental arch in these different positions and to reduce the need for intraoral adjustment. And the more complicated the procedure is, and the more rigid or fixed it is, the more there's a need for such accurate reproduction of mandibular movement and reduction of the need for intraoral adjustment, which will be more troublesome or even impossible. Now, another important tool that is used for reproduction, for programming the articulator and in a way and for achieving accurate mounting uh, for the sake of reproduction of mandibular movement in the laboratory is a face bow. The face bow is a device that is used to relate the maxillary arch to the temporomandibular joints inside the patient's mouth and take that relation and relate the maxillary model in relation to the condyles on the articulator in a similar manner. Okay, and when we do that, okay, then the mandibular arch is going to be related to the maxillary, and therefore it's going to be indirectly related to the temporomandibular joints inside the patient's mouth, and in a relation that will be transferred to the articulator in an effort to reproduce mandibular movements with high degree of accuracy. So here we can see on the upper left photo how the face bow is set inside the external auditory metastasis of the patient. And there's a fork that is fixed to the upper arch, whether it is dentate or, if in eventual case, to the upper bite block. And then there's a joint, three-dimensional joint that is tightened to keep that relation. And then that face bow is going to be used as in C, okay, to mount the upper model, okay, on the articulator in a relation to the temporomandibular joints on the articulator. And by that we can see in B that we have a relation close to what is there inside the patient's mouth. Here is a closer look of the face bow. Of course, this face bow is called arbitrary face bow, in contrast to the kinematic face bow. Kinematic face bow is more sophisticated instrument that is fixed to the post, the maxilla, and the mandible, okay, and we use it to try to find the axis of rotation more accurately. However, it's much more sophisticated than this tool, and therefore we are not going to discuss it. And we'll focus on the arbitrary face bow in this discussion. Why is it arbitrary? Because the axis of rotation or the temporomandibular joint dominant contact is determined arbitrarily. Okay, there's a point called Bergstrom point that is located 13 millimeters anterior to the external auditory meatus on a line that extends from the external or from the tragus, okay, which is part of the rim of the external auditory meatus to the outer canthus of the eye. And that point is considered to be the arbitrary axis of rotation or the arbitrary location of the condyle on that side. Okay, and for convenience, as I said, we use the external auditory meatus to fix the face bow posteriorly, and there is a correction on the articulator that will place the condyle more anterior to the external ear piece. And as I said, this is arbitrarily determined. In contrast, in the kinematic face bow, we attach two pieces, one to the mandible and one to the maxilla. And the one on the mandible, we see the movement of it and we adjust its location until it doesn't move in terminal hinge axis movement. And by that, we can locate where the axis of rotation is. But as I said before, it's too complicated to be learned in this course, and in most of the cases it's too complicated to be used. Here we can see the face bow assembled on the patient's head, the two earpieces inside the external auditory metastasis and tightened, and there is a fork that is related to the upper arch with any suitable material like silicone bite material, and there is a three-dimensional joint that is tightened to keep that relation. And then according to that relation, okay, the maxilla is going to be related to the articulator in a way that will correctly place it in three-dimensional space. And after relating the maxilla, as I said before, the mandible will be related to the maxilla. So indirectly, the mandibular arch is going to be related with more accuracy in relation to the temporomandibular joint. Now, how the maxillary arch is going to be mounted on the articulator using the face bow. Of course, it can move up or down freely. and still be related accurately to the center of rotation. However, this is not very inconvenient because we want it to be related in more anatomical way, and that is why we use a third point reference. As can be seen in A, there is a stylus that is related to an arc on the articulator, and that is a third point reference. Usually that stylus is directed to the infra orbital foramen or inferior rim of the orbit, but in the Facebook that you are going to use in the laboratory, there is a nasion rest. There is a piece that rests on the nose, and that will fix the Facebook in an upward, downward direction, and will be our third point reference that will determine how the upper model is going to be placed, okay, in relation to the upper member of the articulator. In contrast to Facebook mounting, we can have average value mounting. Average value mounting is when we follow the Ponwell triangle, okay, which is an equilateral triangle between the two temporomandibular joints and the contact between the lower two central incisors. And the side length of that equilateral triangle is about 4 inches. So the average value articulator gives us a mounting plate, okay, to which the maxilla and then the mandible is related in accordance with the Ponwell triangle theory. And also, as I said, average value articulators usually have a fixed condylar guidance angle that follows the average of the patients. So it is, in a way, using the average to try to be as close to anatomical as possible, okay, without the need to do sophisticated techniques. But of course, there is an element of error here by ignoring taking extra records. Now we have a huge variety of articulators available there. Like you have many mobile phone types, okay, you have many articulators, okay, but there is an element of cross learning between them. There is similarity that you can use for your convenience to use a different tool, okay, based on your experience with another one, okay. Now, for example, here we have two semi-adjustable articulators, okay. The upper one is an archon articulator because the condyle is in the lower, while the right photo is of a non-archon articulator because the condylar element is on the upper. Again, we can see that the condylar element can be adjusted according to horizontal and lateral condylar guidance angles. Also, the intercondylar distance can be changed here, okay, to conform more to the patient's condition. All these similarities, okay, are aiming at a single objective, is to have an accurate reproduction of maxillomandibular relation. That is the most important thing, and then accurate reproduction of mandibular movement, okay, in order to be able to adjust occlusion in the laboratory properly. In this photo, we can see the value of the incisal pin, incisal table contact, okay, because it will give protection for the vertical separation between the upper and the lower members, okay, and therefore it will be a record for our vertical dimension of occlusion recorded inside the patient's mouth, and whether we want to open the bite or close it on the articulator, then we can have a track of how far we did that opening or closing. Okay, so it's an integral element of articulators that is needed more in complete denture cases because we don't have remaining teeth that will contact and give that vertical dimension of occlusion. Now, just a reminder, the determinants of mandibular movement. We have posterior determinants, which are the two temporomandibular joints, and anterior determinants, which are the contacting teeth. And the neuromuscular system that's going to move the mandible, okay, without violating these determinants. Of course, you cannot force two objects into each other, okay, two rigid objects into each other. Posterior determinants, temporomandibular joints are going to move according to their anatomical relation, and anterior teeth contact is going to dictate the mandibular movement anteriorly, and anything in the middle is going to be governed by these three determinants. Now, if we do protrusion, we know that there is going to be a space posteriorly that is caused by the inclination that the condyle has to travel against when it moves forwards. So when it moves forwards in translation, it has to move downwards as well. And when we move it to one side, it has to translate downwards on the non-working side. Okay. Also the anterior teeth, because they have overjet and overbite, they will force the mandible to move downwards. And how far downwards moving is going to that down, how far that downward movement is going to create a separation between the maxilla and the mandible. And that separation is needed because if we have cusp-fossa relationship, okay, not a flat surface relationship between the opposing teeth, then that relationship is going to cause approximation between the upper and the lower occlusal surfaces when the mandible is moving eccentrically to the right, left on intrusion. And to have harmony, we need to have a harmony between that separation and approximation that's happening. Now here you can see the complicated anatomy of the temporomandibular joint and how it is related to inclined surface of the glenoid fossa. So with any translation, it has to move downwards, okay? And that is one of the main focus points for articulators to be programmed accordingly to reproduce that separation that's going to happen between the mandibular and maxillary occlusal planes that is dictated by the condylar elements and the anterior contact of teeth. Anterior teeth are the other determinant of mandibular movement, okay, because of their overjet-overbite relationship. Then they will dictate how far the mandible is going to move away from the maxilla under the influence of the anterior teeth contact dominance, okay. And if we have, for example, deep overbite and reduced overjet, then there will be a high angle of separation, while if we have an increase overjet and reduce overbite, the angle of separation anterior is going to be less. Now, to summarize things, articulator are integral part of prosthodontic work. They have different types. They differ in their sophistication and programmability. And the more sophisticated the prosthetic work that we are doing, the more sophisticated equipment that we need to use. But at the end, you are the one who is using it, okay? It's not the articulator that's going to do the work, okay? You or the technician is the one who is going to do the work. So if you use sophisticated equipment, you should be equipped with proper knowledge and practice to be able to use it properly. Otherwise, you might end up doing more harm than benefit to the patient or to your prosthetic work. And I hope you will enjoy learning how to use these articulators in your laboratory practice. And as I said before, there is a cross-learning element always, okay? Don't expect that you are going to use the same articulator in the future and you will be confronted with different types of articulators, and you should be ready to understand the differences between them and what they can give and what they cannot give, and how to use them properly without harming your prosthetic work. And good luck to everybody.